really target that high yield stuff, okay? All those red conditions, just don't even bother learning them, okay? Don't even bother learning them. Neuro's only 8 marks out of your 100, okay? You need to really go for the high yield stuff. So I've left these notes for you guys to look at when you go home. I'm not actually going to cover it, the actual second year content. One thing I will say though is that I really recommend you guys learn the Glasgow Coma Scale, because they have totally put in exam questions where you have to calculate people's GCS, okay? Just remember, it's 4 for the eyes, 5 for the mouth, and 6 for your motor skills. And that everyone always gets tripped up about the flexion versus extension to pain. So just remember that flexion to pain is better than extension to pain, because if someone comes at you with a knife, you'd want to put your arms out in front of you. You wouldn't just extend your arms and be like, yes, kill me, please. Therefore, flexion to pain is your decorticate, where you've only lost your brain's cortex, versus extension to pain, which is decerebrate. You've lost your entire brain and you've only got your brainstem left, okay? So the flexion to pain is a primitive reflex that's actually good. Right. So the headache was actually an OSCE station that we had last year, and you need to get really, really good at getting a history for a headache. So aside from your history of presenting complaints, it's also good about asking them, has it ever happened before? Because if it has happened before, it's probably not that serious. If this is a new headache that they've never had before, that's a pretty big red flag, okay? Also ask if there's any precipitating event or any kind of trigger before, and if there's a family history of similar headaches. As far as the systems review goes, I'm essentially just chucking shit at the wall and seeing what sticks. So asking about vision stuff, so photophobia, any vision change, your classic B symptoms, neck stiffness, pain with chewing, any joints or muscle aches or any proximal muscle or joint aches, any recent injury or illness, nausea and vomiting, and then any other focal neurological signs. So differentials wise, the most common ones are going to be a tension, a migraine, or a cluster. Definitely tension and migraine, less so cluster, okay? Tension's the classic like band around the head, and it comes on usually when people are stressed or if they're dehydrated or if they're having a hangover, as you do. Migraines we'll talk a bit more about later on. Cluster headaches are a lot less common than the other two. They sort of like come on a few minutes at a time, go away, and then they come back, and then they go away and then come back. And it's usually like clustered like a few minutes at a time. And it's usually like excruciating pain that's one-sided. But unlike a migraine, they also get like runny eyes, like runny nose, and their eyes usually get like really red on the affected side. So those are your common ones. As far as red flag conditions go, you've got your intracranial bleeds, so your epidurals, your subdurals, and your subarachnoids, and then you've also got your CNS infection, so meningitis and encephalitis. Meningitis and encephalitis is incredibly easy to rule out. You just need to remember to ask about your fever, and if they say they've got a fever, then you need to ask about your photophobia and your neck stiffness, okay? It's really, really easy to rule out, and we'll talk about that stuff later. So there's your subarachnoid. Brain tumors is another red flag, so remember, the headache with a brain tumor is generally worse in the morning because you've been lying down and therefore your intracranial pressure has kind of taken time to increase. So it's a pain that's really bad when you lie down, and when you stand up and kind of go about your day, the pain gets better. They'll also have your classic cancery signs, so your systemic signs, and also if it's an older person, they might have a past history of cancer as well. So it's good to explicitly ask, have you actually been diagnosed with a cancer before? Pitfalls are your classic ones that people don't associate with headaches, so like trigeminal neuralgia, which is more like face pain than it is brain pain, if that makes any sense. GCA as well, so it's more like scalp pain, and it's good to ask them to point like, where does it actually hurt, because they'll point here. And then if they've got pain here, you need to ask them about vision loss on that side, because if they do have vision loss, you really need to act quickly, because we're really up shit creek. Idiopathic or benign intracranial hypertension is something that I didn't actually learn until yesterday when I had to make these slides. So generally occurs in obese women of childbearing age. It kind of just happens. It's just increased ICP without any serious or sinister causes. And we'll talk a bit about it later, but it's not that high yield. Confusion, AKA beware the used car salesman. When you're taking a history about confusion, the key thing is that the collateral's key. You need to ask other people, because if someone's in the midst of being in a confusional state, they're not going to give you straight answers. You need a good understanding about the timeline and how long it took for them to get to this point, because if it's an acute onset thing, it's far more likely to be delirium. If it's been months to years worth of continuous decline, then you'd be thinking about things like dementia. But you don't even need to think about things like dementia, because dementia is not something that you properly learn about until next year, okay? So more often than not, it's going to be an acute onset confusion, in which case you'd be thinking more delirium. You want to think about any kind of preceding events. So if they were sick recently, by far the most common cause of any delirium is preceding sickness, like a UTI or pneumonia. So it's good to take a general systems review, asking about like RESP signs, urinary signs, GI signs. If they were in pain, have they got any pre-existing illnesses? Also good to know about if it's a fluctuating or a constant confusion, okay? Do they have lucid periods in between? And then just try to qualify like what are the actual deficits they've got here. So differentials, you're essentially trying to find out the difference between the delirium and a major NCD, which is formerly known as dementia. We don't use the word demented anymore because it's a bit offensive, because people are sensitive like that. Rule out the delirium before you even consider diagnosing someone with dementia. And the reason for that is because delirium can be treated. And if you don't recognize delirium, you can have some pretty disastrous effects. If you're ever at MMC this year, you might know what I'm talking about. That's all I'll say about that. We'll talk about dementias a bit later, but just know that it's not that important to know. Just know kind of like the general, how you can broadly categorize each dementia, but you don't really have to know it. But you do have to know about delirium. Delirium has a DSM-5 criteria. You don't have to know it. They'll never ask you about it, but it's good to know because it kind of tells you the hallmark signs of delirium, okay? I'm just going to leave that there for you guys to read on your own. There's lots of causes. It's essentially anything, okay? It's essentially anything can give you delirium. The most common ones I've highlighted in red, okay? Alcohol intoxication or withdrawal. More commonly, it's going to be alcohol withdrawal. A lot of high-functioning alcoholics out there, okay? Trust me. And the classic story is this used car salesman or a lawyer or a politician who gets admitted to hospital or gets an operation. It's all uncomplicated, and 2 days later, they just absolutely lose, okay? It's a classic Monash question. It's alcohol withdrawal because they're a used car salesman. Another one's thiamine deficiency, which is also linked to alcoholism. It's what happens if you've been abusing alcohol for too long, or using alcohol, in my term. It manifests in two ways. You've got Wernicke's encephalopathy, which is a reversible thiamine deficiency, and Korsakoff syndrome, which is irreversible brain damage caused by thiamine deficiency. They manifest in different ways. Wernicke's encep is an ophthalmoplegia, an ataxia, and a confusion. Korsakoff's is more of an amnesia, apathy, and a confabulation, where you kind of like make up all these memories that just don't exist. It's not to say that the two are mutually exclusive. You can definitely have one of them superimposed on the other, and that's known as a Wernicke's Korsakoff syndrome. As far as other causes, also think about your infection, because remember, infection is by far the biggest cause of any delirium. And out of the infections, the most common cause of infection to lead to delirium is a UTI. So always do a urine dipstick in anyone who comes in confused, okay? Other ones that might cause it are pain and also constipation, because constipation gives you pain. So always beware the used car salesman or politician being admitted to hospital. That's my little nugget of wisdom. Your examinations are going to be based on your history points. Your investigations are going to be based on your history and exam points. So it's essentially, again, throwing shit at the wall and seeing what sticks. One thing that I will say is, even if they have negative history points and negative exam points, always do a urine dipstick in anyone who's confused, okay? Because remember, UTIs are the biggest cause of delirium, and you can't miss it. It's really easy to treat, and the consequences are absolutely awful if you miss it. Management is essentially trying to treat the cause and then trying to gently coax them back into reality. So just keeping them under close observation so they don't do anything crazy, okay? And then just trying to put things in the environment to remind them that, hey, like, you're actually a human, like, please stop. Another thing I'll also say is that if someone's entered into alcohol withdrawal, you need to give them diazepam. If you spent any time on acute medicine, you would know that, because if you go into alcohol withdrawal, you get seizures, and the seizures can kill you. Diazepam is what you do to control those seizures, okay? So this is a bit of a, like, I was a bit confused when I had to write notes about this, but essentially, in your history of presenting complaint, you'll essentially find out what the cause of the leak is, okay? You'll essentially find out. In fact, you can even find out with one question. How long has this been going on for, okay? That's probably the most important thing, the onset. If it's acute onset, you know something really bad's happened. If this is a gradual onset or it's fluctuating, then you kind of go, what the fuck's going on? So aside from your history of presenting complaint, you should also ask about in your systems review if they've been sick recently. Again, any B symptoms. And is there a pain on top of this weakness? Or is this just an isolated weakness? Also ask about any other deficits they have. If they've got any breathing difficulty, you know this is a really serious condition. Similarly, if they've got swallowing or speech problems, because that's just aspiration just waiting to happen. Any bowel or urinary changes, if they've got incontinence, vision change, sensory change, and also gait change. Have they got any abnormal motions or movements on top of it, like tremor or fasciculation? And also, do they have any proximal muscle weakness, so difficulty walking upstairs or getting up off chairs? Common things are common. The one thing that you've got to rule out is a stroke. And it's really, really easy to rule out because it's going to be someone who's got cardiovascular risk factors, sudden onset, and it's usually painless. Unless it's hemorrhagic, in which case you're going to die. Other common things would be like carpal tunnel syndrome and also like your other single nerve weaknesses. So things like facial nerve palsies and tarsal tunnel syndrome as well. I just put carpal tunnel because it's probably the most common one. And also your Parkinson's disease. When you ask about Parkinson's, the cluster questions I always ask is just TRAP. So T-R-A-P, tremor, rigidity, akinesia, and postural instability. Those are the hallmark signs of Parkinsonism. And as long as you ask that, you can pretty easily rule out Parkinson's. Red flag stuff, again, brain tumors, multiple sclerosis and myasthenia gravis. Multiple sclerosis and myasthenia gravis both happen in young women. They're usually also worse with exertion. They also give you eye symptoms, but multiple sclerosis gives you eye pain. Myasthenia gravis isn't painful. What happens is that they get blurred vision because their eyelids start drooping and they can't hold them up just because of the muscle, just because of the fatigue. The other red flags thing that you need to catch is also motor neuron disease. And the classic thing is just asking them, do you have fasciculations or do you have muscle twitches? Because if they do, that's an instant buzzword for motor neuron disease. This guy's going to die. Pitfall stuff is going to be your non-neurological conditions. So your autoimmune conditions like PMR and also hyperthyroidism. And that's why you ask about the proximal muscle weakness and the proximal pain. So fits, faints, and funny turns is the last sort of presenting complaint to talk about. And I always sort of do my history asking about what things were like before the episode, what happened during the episode, and then what happened after the episode. So what happened before the episode was basically like, what was the patient like? What kind of symptoms did they have? What happened during the episode? So like exactly what actions did they do? And also how long were they out for? And then after the episode, it's basically, well, how's the patient feeling after the episode? The systems review, again, it's quite non-specific, but the reason why you need to take a good systems review is because a fit, faint, or a funny turn can be either syncope or a seizure. And you need to try and tell the difference between syncope and a seizure. And if they've got a seizure, you need to try and find out, well, why did they have a seizure? Okay. And that's essentially what you're trying to ask with these questions. And you can read about it in your own time. The most common causes of a fit, faint, or a funny turn, not even neuro. It's going to be like anxiety. It's going to be like vasovagal syncope and also postural hypos. Your red flag stuff, it's going to be like brain tumor, a stroke or a transient ischemic attack, any kind of cardiovascular condition, infections, hypoglycemia. Hypoglycemia will present very similarly to vasovagal syncope, but the difference between hypo and a vasovagal is that a bad enough hypo will actually give you a real seizure. Vasovagal doesn't give you a seizure, okay? They can have these kind of like little spasmy movements that look a bit like tonic-clonic movements, but it's not a true seizure. Hypoglycemia will give you a real seizure if your blood sugars are low enough. The pitfalls, this is when you actually need to consider epilepsy or seizures. And again, seizures can be provoked or unprovoked. So you need to think about, well, is there a cause to this? You can also think about sleep disorders like OSA. So it's good to also ask about how their sleep's been. And also think about your masquerade. So it's always good to ask about what their mood's been. It'll never be the answer because you're in third year and you don't think about depression, but it's always good to ask because then the examiner's like, oh wow, this person's actually thinking about other things, not just the organic causes. Finally, we're onto the matrix conditions. So we're going to start off with strokes. So there's two types of strokes. You've got your ischemic and your hemorrhagic. And you need to really rule out the hemorrhagic before you can treat the ischemic. Because if you give them clotbuster and it's a hemorrhagic stroke, they're going to die and you're going to get sued. With your ischemics, you've got three different broad causes as far as pathophys goes. You've got your thrombotic, which is where a clot's formed. You've got an embolic, where a clot's formed somewhere else and it's flicked into your brain. Or a hypoperfusion, which is basically when your blood pressure is not high enough to get the blood into your brain. We'll talk about hemorrhagics later. The most important thing about strokes is you need to know your stroke syndromes. You need to know if this area gets infarcted, what symptoms do they get? If this artery gets blocked, what symptoms do they get? Okay. Anterior cerebral artery infarcts will always give you leg signs and cognitive dysfunction. So leg signs, it's going to be leg weakness and leg numbness or leg paresthesia. Okay. It's never going to give you proximal signs because the ACA doesn't perfuse that part. The MCA does, but the MCA also gives you a whole bunch of other things. So the MCA is going to give you your arm and face weakness and also numbness. It'll also give you vision problems. So what's known as a contralateral homonymous hemianopia or quadrantanopia, which is basically when the same side of your vision in both eyes has been blacked out. If it's a dominant MCA infarct, which in most people is going to be the left MCA because most people are right-handed, they might get an aphasia, either a Wernicke's or a Broca's. If you've got a Wernicke's aphasia, it's when you can speak very fluently, but the words just don't make any sense. If it's a Broca's aphasia, it's when your cognition's fine and you know what the right words are, but the words just don't come out. It's quite sad because a lot of these people end up committing suicide. If it's a non-dominant MCA infarct, you can also end up with what's known as a contralateral hemi-neglect, which is when your vision's fine, but you just ignore everything in that side that's been affected. So if it's a right MCA infarct, in other words, a non-dominant MCA, you end up with left hemi-neglect. And so if someone stands on your left and says hello, they just ignore you. So PICA, or the posterior inferior cerebellar artery, causes this thing called lateral medullary syndrome. They talked about it a lot in second year, and then they never really talked about it again. Is it high yield? Not really. I'm just going to move on. As long as you remember your rules of 4 and remember what's in the lateral medulla or the lateral brainstem, you can essentially reason out what the symptoms are. Lastly, the PCA, or the posterior cerebral artery, is mostly going to give you vision signs, okay? So the most important difference between a PCA infarct and an MCA infarct is that a PCA infarct is macular sparing. So in other words, the center of your vision is still preserved, even if you've lost half your visual field or a quarter. That's because information from the macula of both eyes actually gets sent to both lobes of the brain. So if you lose one lobe, you've still got the other lobe that can provide the information for both maculas. So it's a macular sparing hemianopia or quadrantanopia. If you get a bilateral loss, you get what's called cortical blindness, which is when you can still see, but you can't see. So they're like, you'll be like, can you see this? And they'll be like, yeah. And they'll be like, what is it? And they're like, I don't know. And that's what cortical blindness is. So here's a nice diagram that kind of shows you the differences. You can see everything, basically everything from the optic chiasm from point D up to point G is all MCA stuff. Everything in here is basically all PCA. And that's just a nice way of thinking about it. Yeah.
So with the MCA strokes, so you would lose your macula, lose half your macula.
Yeah. So rather than having like a little circle in the middle that's preserved, yeah, it's just straight. It's just a straight hemicircle that you've lost. So they also introduced this idea of a lacunar infarct. Okay. A lacunar infarct is essentially an infarct of your deep white matter, also known as the subcortex, because it's underneath your cerebral cortex. There's only 2 structures that you need to know for your Monash exams: the internal capsule and the thalamus. If you've got pure contralateral motor loss, but normal sensation, it is an internal capsule stroke. If you've got pure contralateral sensory loss, but your motor function's fine, that's a thalamic stroke. That's all I need you to know. Motor loss, internal capsule; sensory loss, thalamus. Your investigations are going to be very similar to a heart attack, except you need to really do that CT brain very quickly, because you need to really quickly rule out, is this a hemorrhagic or an ischemic stroke? Okay. You also need to find out the cause of the stroke. So you do ECG for atrial fibrillation. You can do a carotid Doppler for carotid stenosis if a plaque's flicked up into your brain. Do an echo if any clots in their heart, sitting in their heart, like if they've got AFib. And you can also do a CT or an MRI or a CT angio, which will actually show which artery is being blocked. And that can help you in your future treatment. You also do a whole bunch of other kind of bloods, because remember, we're considering giving them clot buster. So you also got to get a group and hold and a coagulation on the side. Management, you always start off with doctor's ABCD, okay? If your examiner asks you, what are you going to do for this guy? And you just say, oh yeah, I'm going to give him the clot buster. Congratulations, you got 1 mark. You've lost the other 3 because you didn't say anything else. You've always got to think about it like an intern. What does an intern have to do? The intern has to think about the doctor's ABCD, the calling the neurologist, the calling the gen med, getting the bloods, putting the line in. That's all the stuff that you've got to talk about, okay? There's a bunch of strict guidelines on what you can actually do, but essentially you either clot bust them or you can send them to the interventional neurologist and they can pull the clot out using a catheter. Intracerebral is very similar, except instead of giving them clot buster, you give them anti-clot buster. So you try and stop them from bleeding out, and you try and keep their blood pressure in a nice happy medium between not high enough that it will just keep bleeding, but not low enough that they'll lose perfusion to their brain. And we'll talk about subarachnoids later. So migraines, probably one of the most common causes of headaches in young people. If this is an older person with a new onset headache, it's probably not a migraine, okay? Most people get it most people start getting them in their adolescence. There's lots of different triggers, and the triggers are also very common with tension headaches, but it's always good to explore. Most people have a prodrome a day or 2 beforehand where they just kind of feel not quite right. Right before the headache, some people have what's called an aura, where they get these like zigzag lines in the field, in the peripheral vision. They might get some stroke-like symptoms like vision loss. They might get hemiplegic. They might lose sensation, okay? They get the headache, and then afterwards they get a prodrome where they just kind of feel like crap. You can have that. You don't have to. What defines a migraine is the actual pattern of the headache itself. It's usually one-sided, usually lasts hours to days. It's pulsating. It's pretty bad, okay? If you've got that friend that's like, oh, I had a migraine yesterday. Oh, so bad. No, bullshit. They didn't have a migraine. Migraines are debilitating. You got to like take time off work because they're that bad, okay? And the classic other associated signs are like nausea and vomiting, and also some kind of sensitivity to your sensation. So either light, sound, or smell. But the Monash one is light. Non-pharm treatment, you want to find out what the triggers are through a headache diary and then avoid them. And then maintain a consistent, healthy lifestyle, because that decreases your chances of getting future migraines. In an acute management, you give them high-dose NSAIDs. If that doesn't work, you give them a triptan. And if that doesn't work, you give them an ergot. I've never heard of an ergot, but I have heard of triptan, so you can stop about there. If they're feeling nauseous, you can also give them some antiemetic. The classic one that Monash, I think, wants you to know is prochlorperazine, also known as Stemetil. So if they're getting lots and lots of migraines, you can think about putting them on prophylaxis. You don't need to give everyone prophylaxis. It's only if they get them a lot. You don't even have to remember these. I only remembered like beta blockers, honestly. If this is a woman on the oral contraceptive and they get migraines with auras, you can't put them on the contraceptive because that could give them a stroke. And that's because COCP makes your blood extra clotty. And what happens is that you get vasoconstriction. So that together can give them a stroke. So don't put them on estrogen, put them on something else. So as far as intracranial hemorrhages go, you've got 3, but you've got the 2, the epidural and the subdural, that are quite similar. Both of them are caused by head injury, but an epidural is associated with skull fractures, whereas subdurals don't have to be, okay? The classic history for a subdural is some old guy falling over and hitting their head on the ground. That's all it takes for a subdural. They don't have to fracture their skull. Epidurals, on the other hand, are associated with your pterion fractures, which damage the middle meningeal artery. So what happens in an epidural is that they usually have what's known as a lucid period where they're GCS15 completely fine, and then all of a sudden they deteriorate and die. Subdurals, it's a continuous decline from the injury all the way until they die. When you do imaging of an epidural, you get what's called the red lemon. It's this elliptical shaped hematoma, and that's because the bleed is limited by the sutures where the dura mater is adhered to in the skull. Subdurals, because it's in the subdural space, it's not limited by sutures. So you get this, what's known as the blue banana, because it's a venous bleed. I know, people are stupid. It's a crescent-shaped hematoma because it's not limited by those sutures, okay? If someone's had a long-standing subdural, it can also end up looking a lot like just regular brain tissue, so sometimes it's really hard to pick out. Management of an epidural, well, it's a surgical emergency. These guys get emergency treatment. They just open up the skull and suck it out. Subdurals depend on how big it is, depends on how acute it is. If it's a small bleed, you can usually wait it out and just keep scanning and hope it doesn't get too big. If it gets big enough, you can drain it out. If it's really big and they're acutely deteriorating, you just treat it as like an epidural. So in a fall with head strike, you've always got to investigate for a subdural hematoma, okay? Always. If someone falls over and hits their head, they get a scan. So that's what an epidural hematoma looks like. This is what a subdural looks like. Now in this picture, you can see the acute subdural there, but a chronic subdural can actually look quite hidden. So that's actually in here, okay? The clue is because you can see the sulci here, but you can't really see it on this side. So that's usually the hint that they've got a little subdural there. Your subarachnoids is always the worst of the three, okay? And it's usually caused by a popped berry aneurysm. And the classic buzzword for berry aneurysms is polycystic kidney disease. There's always a Monash question about family members dying from strokes. Yeah, they've got polycystic kidney disease, okay? There's a bunch of other things, but like Monash doesn't care about that stuff. It's polycystic kidneys. It's a sudden onset, worst headache ever. They call it the thunderclap headache because it's just out of nowhere, okay? Some people have what's known as the sentinel bleed, where the berry aneurysm leaks a little bit before it finally explodes, and that gives them a milder form of this current headache a few weeks beforehand. And there's a Monash question where someone comes in with a thunderclap headache, and they talk about how they've had a migraine or something a few weeks before. Yeah, bullshit, that's not a migraine, that was a sentinel bleed, okay? Don't get fooled. They'll also have signs of meningism as well, because it's blood in the subarachnoid space and it really irritates them. And when you scan them, you get the very classic subarachnoid sign. It's a surgical emergency. These guys need to see a neurosurgeon right away to clip that popped aneurysm. Half the people with subarachnoids end up dying, and a third of the remainder with lifelong disability. So that's what the subarachnoid looks like. It's the classic spider hemorrhage because it's just receding into the subarachnoid space. All right. Oh, I'm really tired. Seizures. Okay. So remember with your seizures that they can either be provoked or unprovoked, and you only have epilepsy if you're getting unprovoked seizures. There's two broad categories. You've got your partial or your focal, and you've also got your generalized. So with your focals, you've only got your simple and your complex. So simple if they're aware of it, complex if they're not. Generalized, there's quite a few. There's quite a few different types, but there's only two that you actually need to know. You don't really need to know the rest. Just remember your absence seizures, the ones that commonly happen in kids where they just stop and start blinking or lip smacking. And also your generalized tonic-clonics, which is like the classic when someone says, I've got epilepsy, it's the classic seizure that everyone thinks about. It's also known as the grand mal. And what happens is they usually have this like aura of just feeling not quite right. And then right beforehand, they get what's known as the preictal cry, which is this like guttural scream because their diaphragm contracts and just forces all the air out of their lungs. They fall to the ground in the tonic phase where all the muscles turn rigid. And then they have a clonic phase where they have rhythmic jerking. Afterwards, they've got the post-ictal phase, which is essentially when they just feel like just absolutely pooped and everything's painful, and they might become double incontinent as well. So it's always good to ask about their, if someone's had a fit, faint, or a funny tone, it's good to ask about their sphincters, so whether or not they wet themselves or soiled their pants. So when you're investigating, again, you're confirming it's a seizure, and then after that, you're trying to find out why they had a seizure. So that's essentially what you're trying to do with your investigations. If it's an older person, always remember to do a urine drug screen because a lot of drugs, particularly stimulants, can actually cause people to have seizures. And do their blood alcohol as well. You can also do your imaging and your lumbar puncture, but ultimately you want to do the EEG because that's what's going to confirm, yes, this is actually a seizure. Management is avoiding the triggers. Also some psychosocial issues, educating the patient, and also just trying to like reinforce that the stigma about epilepsy is not true. There's a lot of safety issues. These guys need to spend a great deal of time seizure-free before they can get their license back. Don't operate any heavy machinery, don't bathe, and also don't swim alone. As far as medications go, you usually start with either valproate or carbamazepine. That's essentially the only two you need to know. There's other ones worth knowing, but those are essentially the only two, okay? There's a few others that I put here, like lamotrigine, Keppra, phenytoin, pregabalin, gabapentin, oxcarbazepine, but you don't really have to know those. Pregnancy counseling, as far as women, all anti-epileptic drugs carry a risk of giving neural tube defects. Valproate is by far the worst. Lamotrigine is the least worst, so it's still bad. So you need to balance the risk of having spina bifida versus the risk of having a seizure in pregnancy, which could potentially kill the baby. So you try and get the dose down to as low as possible when they're pregnant, give them high dose folate, or you can try and change them onto a not valproate drug. That being said, most of your pregnancies will be normal and uncomplicated. If the first line drug doesn't work, you just keep adding drugs gradually until it comes under control. And if it comes under control, then you gradually start taking them off the first drugs. And always give contraception to women of childbearing age. Neuro-oncology, oh boy. Most brain tumors are metastatic, okay? Only about 50% of them are actually primary brain tumors. The people that tend to get primary brain tumors are children because they haven't lived long enough to make life mistakes. Okay. I gathered myself. Okay, so astrocytomas, right. Astrocytomas are by far your most common primary brain tumor. There's 4 grades depending on how malignant they are. The most malignant is known as the glioblastoma multiforme, or the GBM, or the butterfly tumor. Most brain tumors will stay in the hemisphere that they originated from, not GBM. GBM is so aggressive it can cross into the other hemisphere, and that's why they call it the butterfly tumor, because as you can see in this MRI of the brain, it's actually crossed the corpus callosum into the other side. It's got a very, very classic imaging on MRI because it's got that mixed sort of growth and necrosis at the same time. And that's why you get those patchy white and black spots. That's cells dying. In contrast, the meningioma is a very slow growing, usually benign tumor of the meninges. It arises from the arachnoid mater. And unlike glioblastoma multiforme, when you image a meningioma, it's all the same color because it grows so slowly that the cells on the inside haven't even started dying yet. The good thing about it is that you can often take it out in its entirety. And if you take it out in its entirety, the person's essentially cured. It'll never come back. Acoustic neuromas are a bit of a misnomer. It grows near cranial nerve 8, but it tends to affect the vestibular part of cranial nerve 8 more than the acoustic part. And it's actually a growth of Schwann cells rather than nerve cells. The classic symptoms are a triad of sensory neural hearing loss, tinnitus, and also disequilibrium, where you kind of feel like everything's off kilter, so you walk like that, like tilted. Pituitary adenomas, I'm sure Tishar's probably talked about it. Pituitary adenomas can be either hormone secreting or non-secreting. The most common hormone, if it is hormone secreting, is prolactin. And the classic signs are either galactorrhea or gynecomastia. You can get other hormones, but by far the most common one is a prolactinoma. Mass effect signs as well. You get the classic one is bitemporal hemianopia, where you lose your temporal field of vision. And craniopharyngioma is essentially just the differential for a non-hormone secreting pituitary adenoma. Remember, 50% of all brain tumors are metastatic, and it often occurs at the junction of your gray and your white matter, just because it does. And there's often multiple spots present. There's a lot of very common origins, but the key thing is if you're suspecting a metastatic brain tumor, you need to ask about that past history of cancer. And if you get one, it's not good. So clinical features, you're gonna have your classic cancer B symptoms. You'll have your headache worst in the morning because you've been lying down. And they'll also have other signs of raised ICP. So papilledema is your classic one, nausea and vomiting. and maybe some other focal neurological signs. Investigations, you do some imaging, you can try a biopsy, but if it's a metastatic tumor, you've got to find out where the cancer came from. So you've got to search the whole body. Management is a mix of just your classic cancer management, surgery, chemo, radio, pal care if we're reaching the end. If they've got raised ICP, the drug of choice to treat that is dexamethasone, okay? That'll shrink the tumor and it'll sort of decrease the symptoms of raised ICP. Okay, have you guys had your infectious diseases talk yet? Okay, so we'll just kind of zoom through this. Bacterial meningitis. Most meningitis is caused by viruses, but we don't care about the viruses because the viruses are usually self-limiting and benign. Bacterial meningitis will kill you within the day once you start getting symptoms. So it's a medical emergency, and it's one of those few times where you actually initiate treatment before you've taken a sample for a culture. Usually you want to take a sample before you give them antibiotics, because if you give them antibiotics, you'll kill everything in the culture. You can't grow anything. You don't know what good antibiotic there is. Not in bacterial meningitis. You don't have time. They'll die. The only 3 bugs that you need to know: strep pneumonia, Neisseria meningitidis, and Listeria monocytogenes. Strep pneumonia and Neisseria are going to be your most common causes in your general population. Listeria is more common if you're over the age of 50 and you're immunocompromised. So all you need to do is just remember these 3 and you're good. You don't need to know any of the others until next year. So your clinical features, the classic stuff is going to be your meningism, your fever and your meningism. Photophobia, a few other specific signs like Koenig's and Brzezinski sign that you can look up. Neck rigidity, epistotonus if you're young, which is basically when your whole body arches into extension and you like form a very convincing bridge on the bed. If you get a non-blanching petechial rash or a non-blanching purpuric rash, that is specific for meningococcal sepsis, okay? If they get non-blanching petechial rash, this isn't just any bacterial meningitis, this is meningococcal. And they'll also get signs of raised ICP and seizures, and also a very, very rapid deterioration, like minutes to hours. Investigations, the most important thing that you ever need to say to the examiner is that if you suspect bacterial meningitis, you will initiate antibiotics before you start the investigations, okay? So you essentially just swab down their entire body for any bugs, and you do your general bloods, you do the CT, and then you do the lumbar puncture. You need to do the CT before the lumbar puncture because you can't put in a needle if they've got raised ICP. You will kill them. And remember, start the antibiotics before the lumbar puncture results return. What antibiotics, you say? Well, before even talking about antibiotics, you've also got to do your doctor's ABCD, you've got to do your sepsis 6, you've got to do your fluid resuscitation. Remember, don't just talk about the ultimate heroic treatment. You've also got to think about the other things. That's what's going to get you the marks in the OSCE. Empiric therapy for bacterial meningitis, ceftriaxone and dexamethasone simultaneously. But Monash doesn't care about ETG. If they get a non-blanching purpuric or a non-blanching petechial rash, don't give them ceftriaxone, give them benzylpenicillin, because benzylpenicillin is the specific antibiotic for Neisseria meningitidis. Once you've started them on Kef and Dex, or in Monash world, once you've started them on benzylpenicillin if they've got a non-blanching petechial rash, you essentially wait for the MCS results of the LP and you change your antibiotics as it is. And most of these people need to go to ICU. So non-blanching petechial rash, give them benzylpenicillin. That's the antibiotic of choice in Monash land. Viral encephalitis is essentially just a differential for meningitis. The only difference in the clinical presentation, because they're very similar, is that viral encephalitis will also have focal neurological signs. So they'll have some kind of like stroke-like signs. But you don't really need to know much about it, really, because it's a red condition, and red conditions are not high yield. So it's exactly the same as bacterial meningitis. Any clinical suspicion, you start the antimicrobial treatment immediately. What antimicrobial treatment? It's acyclovir. It's essentially acyclovir and 10 Hail Marys, because if you've got viral encephalitis, it's not looking good. Spinal disorders are really low yields. I'm just going to zoom through. Spinal canal stenosis is just a gradual narrowing of your spinal canal. So it's gradual is the key thing. Dysprolapse is the acute onset, usually one-sided pain and weakness, classically sciatica, which is like the back of your leg. And that's essentially all you need to know. Here's a nice diagram. Look at that. You usually don't need to operate for a disc prolapse. You can usually wait it out and it will usually go away on its own. Cauda equina syndrome is a surgical emergency, okay? And the hallmark signs of cauda equina syndrome are double incontinence, so urinary fecal incontinence, saddle anesthesia, which is numbness in the insides of your thighs and your perineal region, and an altered gait, okay? If they've got those signs, you really need to call the surgeon immediately, and they get a laminectomy where they take out the vertebral arch on the affected part. So spinal cord injuries are pretty low yield. There's 4 of them. Your hemisection or your Brown-Séquard syndrome will give you loss of motor function and also loss of DCML sensation on the affected side, and your